On television, a coma usually looks like a long, peaceful nap. The patient lies perfectly still, eyes closed, quietly waiting for a miraculous cure to wake them up. But beneath that calm surface, the brain is locked in a chaotic struggle. To understand what's actually happening, we have to look at how doctors define human consciousness. It requires two basic things: being awake, meaning you have basic physical reflexes like opening your eyes, and being aware, meaning you can process what's going on around you. In a coma, both of those systems power down. This is completely different from a deep sleep. When you fall asleep, your brain still cycles through active periods of rapid eye movement, generating electrical activity similar to when you're awake. A comatose brain stops doing that. Those regular cycles vanish entirely. This chart breaks down brain energy consumption across different states. When you're awake, you're operating at 100%. Deep sleep drops that activity down to about 60%, but a coma plunges down to roughly 40 or 50%, using significantly less energy than even your heaviest slumber. Biologically, a coma is a total neurological disconnect. Medical professionals actually compare the state much more closely to being under general anesthesia than to sleeping. Comas usually follow a violent physiological event. That could be a massive physical impact to the head, a severe stroke, or prolonged oxygen deprivation. When the brain takes that kind of extreme damage, it shuts itself down to conserve energy and focus entirely on survival. Sometimes doctors have to force this process. In a medically induced coma, they use heavy sedatives to intentionally suppress the brain's electrical activity and drastically slow down its metabolism. They do this because an injured brain swells. Because the human skull is a rigid container, that swelling has nowhere to go. Without intervention, expanding brain tissue will crush itself against the bone, starving specific regions of oxygen and causing permanent damage. So the medical team places the body in a suspended, carefully managed state. The physical self is kept safe on life support, but the mind is left entirely alone in the dark. Inside the ICU, doctors have to figure out exactly how deep that darkness goes. They rely on strict, data-driven metrics to quantify a patient's level of unconsciousness. This is the Glasgow Coma Scale, the primary tool used to measure severity. It scores a patient from 3 to 15 based on 3 specific criteria: whether they open their eyes, if they make any verbal sounds, and how their motor reflexes respond to stimuli. A patient might fall into a vegetative state, located here on the lower middle of the scale. In this state, a person might yawn, grunt, or have basic reflexes, which can give their family an immense amount of hope. But these are strictly involuntary movements. There is zero actual awareness. Sliding further down the scale, we reach catatonia. This is the complete absence of any physical movement or reflex at all. Patients here are completely unresponsive and often require machines to breathe for them. Pinned at the absolute bottom value of 3 is brain death. This means the higher brain functions are entirely and irreversibly disabled, with only the most basic autonomic functions remaining intact. These clinical definitions are useful for mapping the physical boundaries of the body, but they entirely miss the subjective, often hallucinatory experience happening inside the patient's head. While a patient appears completely unresponsive on the outside, their damaged brain is often desperately trying to make sense of the world. Because the regular sensory networks are disrupted, the brain takes real physical stimuli from the hospital room and scrambles them into bizarre, vivid hallucinations. For example, one survivor recounted how doctors placed her bed in the Trendelenburg position, literally tilting her body upside down to manage blood flow. Her isolated brain processed that extreme physical shift by convincing her she was tangled in a hammock, hanging upside down and unable to move. When she developed a massive fever, nurses covered her body in ice packs to bring her temperature down. Her comatose mind translated that intense cold into a vivid, prolonged trip to the freezing, pine-covered wilderness of Alaska. Sounds crossed that boundary too. Neuroscientist Dr. Teresa Pape mapped this sensory crossover by performing brain scans on 15 coma patients to see exactly how their brains reacted to voices. This illustration maps out her findings. When patients heard unfamiliar voices, Their brain scans showed almost zero activity, but when they heard close relatives calling their names or telling recognizable stories, those neural networks lit up automatically. Because of this, doctors actively encourage families to talk to, read to, and play favorite music for their unconscious loved ones. The working theory is that processing those familiar sounds actively exercises damaged neural connections and can speed up recovery. The outside environment actively shapes the coma dreamscape. A familiar voice or a sudden drop in temperature serves as an invisible tether, linking the sterile medical room to a mind wandering through its own hallucinations. The cinematic image of a patient suddenly sitting up and speaking is a myth. In reality, waking up is a slow, grueling process of neurological detoxification as sedatives gradually leave the system. As the brain reboots, many patients experience ICU psychosis. Their mind exists halfway between the vivid nightmares we've been trapped in and the stark reality of the hospital room, leaving them entirely unable to tell the difference between the two. Survivors describe having to develop an exhausting mental coping mechanism. They have to sit with their families and manually sift through their fragmented memories, putting verified events into a real folder in their minds and banishing the rest to a dream folder. While they fight that mental battle, they also reckon with the sheer physical devastation of being immobile for weeks or months. Without daily movement, muscles rapidly atrophy, and constant pressure against the mattress creates deep, dangerous bed sores. One survivor described the utter terror of finally trying to lift her leg off the bed. She managed to raise the bone, but her muscle mass had wasted away so severely that it just sagged against the mattress, leaving her feeling trapped in an alien body. That physical weakness is paired with intense panic. Patients often wake up with a breathing tube shoved down their throat, their wrists physically strapped to the bed frames to keep them from pulling out their IVs, and entirely unable to speak or ask for help. Reclaiming their life takes a massive physical toll. Patients spend months in extensive physical therapy, relying on specialists to help them rebuild their atrophied muscles and literally retrain their nervous system to perform the most basic human movements. Surviving the coma is an incredible medical achievement, but the true battle begins after the machines are turned off. It is an arduous, years-long fight to reconstruct reality, parse the hallucinations, and reclaim a body that was left behind in the dark.